Hi, Vanessa.
Hi, Cara.
This episode with Avrum Bluming is amazing.
It's a
And
barnstormer.
it's a barnstormer. And I just want to tee it up with a little bit of description for what is coming in the next almost hour of conversation, because we get requests everywhere, emails, DMs. I get phone calls, I get texts, people begging and begging for more information about not just menopause and the intersection of puberty and menopause, but like, what are you supposed to believe? What's the data? What are you supposed to, how how you're supposed to put your own life preserver on first? Well, when it comes to symptomatic perimenopause and menopause, people have to put their own life preserver on. They have to take care of their own health in order to then take care of all the other people in their lives, including tweens and teens who are counting on them. And this episode is unbelievable because we have with us Avrum Bluming, who I'll get to his bio in a second, but he is the author, one of the two authors of Estrogen Matters. First came out in 2018, re-released this year with updated data that really spoon feeds everyone from doctors to non-doctors and everything in between with all the information you need to know to answer the question, how do I care for myself during this period?
Yeah, I mean, essentially what the conversation entails is a passionate and complex dismantling of so much of what we have been told about our bodies, about estrogen, about breast cancer, about risk of heart attack, about osteoporosis, about brain fog, about all of it. He takes the headlines that have been screaming at us for the last 20 years and dives beneath those headlines and helps us understand that actually the headlines are not true and in some cases patently false. And what the data and reams of studies and research actually does tell us and does teach us, and how people with uteruses and without uteruses, people who have had estrogen coursing through their bodies for decades and now don't, how we can take good care of ourselves in the moment and also help prepare for our future health. He is just a total, wonderfully passionate, insightful, and really, really, I don't want to say this, but it may be the first time anyone's ever called someone a liar on our podcast. I'm just saying.
I don't want to spoiler alert, but the most perfect part of this episode is that where he lands is how, yes, he calls people liars. He does. But how at the end of the day, everyone is actually coming around to the same place because the data is the data. And so we encourage you to listen all the way through, even if you have to do it in little fits and starts, because there is so much here. Quick bio. Avrum Bluming is a hematologist and medical oncologist. He is, I didn't even know this existed, a master of the American College of Physicians, which apparently is an award bestowed on fewer than 500 of the 100,000 board certified internists in the United States. There's a reason I didn't know that existed. He is very, very special.
I would make you a master of the American College.
He's an emeritus clinical professor of medicine at USC, a former senior investigator for the National Cancer Institute. And as you will hear, he is one of the most thoughtful and thought-provoking people we have ever interviewed. We hope you enjoy. Hi, Avrum.
Hello, Cara.
I feel like doctor to doctor, we have to do the thing at the top of this podcast, which is make our disclosures. So I'm going to start with my disclosure.
Perfect.
I have known you since I was in high school. And I haven't really known you. I mean, I think if we bumped into each other walking down the street, we wouldn't maybe even now we would recognize each other. But up until today, I don't think so. But your daughter, Ariel, was one of my good friends in high school. And I adore her and she's amazing. And that is our direct connection to you. So that's my disclosure.
I'm so glad you started with disclosure because we are going to talk about a product that is marketed. And Carol Tavris, my social psychologist co-author, makes it very clear that we are on nobody's payroll. We get no money from anybody, certainly not from drug companies, not from marketers. And so anything we say at least doesn't have that possible taint.
And our
That's
listeners,
disclosure too.
I love that. Our listeners, in case you don't know, that's a real disclosure. That's really what we're supposed to be saying when we disclose.
And
Okay.
Avrum, did we pay you to be on this podcast?
If you did, it was done in secret because you never offered and I never asked.
We did not pay Avrum to be on. Just we were paying him with the pleasure of our company and conversation. That is the only payment he's receiving today.
And time, the most valuable thing we all share.
That
Correct.
is right.
Now he's gone very deep. So with that, we're gonna dive into the heart of the conversation. My disclosure for anyone listening to this podcast for the first time is I am not a doctor. That is my disclosure. I have an honorary degree from Cara that is little m, little d, but I am not a physician. So just so we're all clear. So Avrum, we are so thrilled to have you here. I had the privilege of hearing you speak at the Swell event last year in New York. And I was like, who is that? He is amazing. And I texted Cara after I heard you speak. And she was like, I think I have a way to get to him. And I was like, oh, great. And then she didn't even realize she'd finally made the connection 10 months later. I want to start by talking about, you're an oncologist, right? But your work is really focused on estrogen. You wrote with Carol this incredible book, Estrogen Matters, which is a fascinating read. And I will not spoil any of the twists and turns and drama in it. But before we get to that part of the roller coaster, I would love it if you could just remind our listeners what the role of estrogen is in the body as people move through stages of life, because we're going to dive in one particular stage.
If I can, Vanessa, you mentioned that I'm an oncologist, and I'm not an endocrinologist who specializes in hormone treatment, and I'm not an obstetrician gynecologist. And so let me just explain why we are here discussing estrogen and possibly progesterone for peri and postmenopausal women. As a medical oncologist, about 60% of my practice for over 40 years was involved with breast cancer treatment. And it's been a very exciting period of time where I've watched the fear of breast cancer retreat in the face of medical advances. Now, it's not gone, and I have a lot of respect for cancer and breast cancer, but currently in the United States, the cure rate for newly diagnosed breast cancer is better than 95%. And cure rate means if you follow women who were treated until they die at about the same rate as women who never had breast cancer. And the overwhelming majority never have it come back. So that even though it's a red flag, it's worth knowing that we can deal with it. However, there are costs to that treatment. And many times the costs, which can involve chemotherapy or can involve forms of therapy that were marketed as blocking hormones, result in symptoms. And women would complain to me about the symptoms. And being a reasonably empathetic person, I would listen carefully, but in the front of my mind, I'd be thinking, there's a very good chance you're cured of cancer. And I'm sorry if you're having symptoms, but deal with it. Until my wife at age 45, had breast cancer, and I treated her with chemotherapy, and she doesn't complain. And she came down with the symptoms, which she didn't even bring up in our conversations until she felt brain fog. Martha, my wife, is a voracious reader, and she found that she couldn't follow the pages of a book that she was reading, the plot. After 2 or 3 pages, she wouldn't remember what she had been reading, and that was intolerable. And that really started me many, many years ago on this quest to find out if there were any way I could help. And what I found is that when women with breast cancer are treated with chemotherapy, pre or perimenopausal women, they often go into precipitous menopause.
Mhm.
It's worth mentioning that there is andropause, which is the male equivalent, but andropause, the hormones diminish at a very slow rate. In women, the hormone levels drop precipitously, so that there are very few symptoms associated with men getting older vis-a-vis the diminution in testosterone, whereas women have dramatic symptoms.
And can we just go a little bit system by system
Sure.
to help people understand? So maybe let's start with the reproductive system, right? So when estrogen drops precipitously,
Yes.
what happens?
First, you said reproductive system, it becomes harder to get pregnant. It may be impossible to get pregnant, but that's not a guarantee. But what happens is there are symptoms that appear, and the symptoms that everybody knows about are hot flushes and night sweats. There are a plethora of symptoms that people don't know about. I mentioned brain fog. Most of them don't know about brain fog. If you start feeling palpitations, your heart is beating quickly or irregularly, that's worrisome. You're getting older. You're in your 40s, maybe early 50s. So you go to a cardiologist. And today, most of the cardiologists still don't know that palpitations are a sign of estrogen deficiency.
I will say my cardiologist husband literally turned to me last night because he knew that we were interviewing you today. And he said to me, I have become a very different cardiologist having watched you go through perimenopause. He said, I just didn't know any of this. And none of us were trained in medical school, and none of us who follow the literature could even follow these through lines and all of these different, there are all these different stories that are told by perimenopause. I mean, it's also bones. I'd love you to talk about bones. I'd love you to talk about depression, mental health, right?
Yes, I'll get into all of that. The fact that you and I weren't taught in medical school about that is not surprising in face of the fact that less than 25% of OBGYN fellowships deal with menopause. And when they do, they usually spend several hours, and that's the extent of the treatment of menopause. So that we spoke about hot flushes and night sweats. We spoke about palpitations, that it also can be accompanied with chest pain, joint pain, the symptoms, genitourinary symptoms of vaginal discomfort, painful sexual intercourse, frequent urinary tract infections, and loss of sexual desire, and obviously difficulty concentrating, brain fog. We spoke about that. There's also an increased risk of significant cardiac pathology that can develop. There's an increased risk of hip fracture, actually any kind of fracture, but hip fracture is associated with a death rate that is similar to the death rate of breast cancer, which is about 41,000 women in the United States per year. And the brain fog can actually lead to cognitive decline and Alzheimer's disease. And what we now know is that hormones, and just so we specify, hormones really refers to estrogen primarily. The problem with estrogen alone is in a woman who still has a uterus, estrogen does increase the risk of uterine cancer. And if progesterone is added to estrogen, that increase is not only nullified, the result is a lower risk of uterine cancer than if the woman were never on hormones at all.
So I just want to pause here for a second, because what you are describing is an astounding universe of symptoms that affect the mental health, the cognitive well-being, the skeletal health, the cardiac health, the reproductive health, and all of the relational impacts, right? Sexual relationships, family relationships, parenting relationships. I mean, you are essentially describing a world that, as you say in the book, Avrum, almost becomes intolerable, that people describe their experience through this journey, either caused by, a treatment for their cancer or through the natural evolution of perimenopause and menopause. But my God, it is so upsetting. I mean, it is so upsetting and I'm saying this, Avrum, because we're setting the conversation up for the second part of where we're going to go. But when you talk so beautifully in the book about your personal experience with your own wife through this journey, what was the aha moment for you as both a medical practitioner and a spouse, recognizing this entire constellation of symptoms?
Well, just to add, it also, as you heard, decreases lifespan and, even more importantly, decreases health span, the period of time that you live in a relatively healthy environment. The aha moment was trying to help Martha with the brain fog and peripherally help the other patients under my care, and realizing that the assumption that estrogen causes breast cancer, a logical assumption, because breast cancer is 100 times more frequent in women than it is in men, but it's wrong. And it's important to recognize that it's wrong. And if it's wrong, and if estrogen is a way of dealing with all the things we have listed, it's at least worth looking at instead of discounting without adequate information.
So, Avrum, you just set us up for the crux of the tension here. If you could lay out for us, on the one hand, the positives of estrogen, or vice versa, the negative impacts of not having estrogen. That's like 18 double negatives. I apologize for the structure of that sentence. And the concern about breast cancer, right? Which is what you do day in and day out, treating people, hopefully curing people of breast cancer. Where does it come in? Explain for lay people how the estrogen concern relates to breast cancer for people who don't have the level of knowledge that you and Cara have.
Well, what happened with the Women's Health Initiative, which we have referred to, which is, by the way, the most expensive study ever underwritten by our government. It is currently up over $1 billion. And it was actually developed by Bernadine Healy, the first female director of the National Institutes of Health, because she said, all the studies that are done in medicine are done on men, not just on men, on male animals, not just on male animals, on male cells. And they are then extrapolated to women who are almost like men. Well, no, they're not. I mean, there are big differences which we were completely ignorant of. And she wanted a study that catered to the needs of women. So, for example, we spoke about the menopausal symptoms. Well, if you stop somebody on the street, male or female, and say, how many women going through perimenopause or menopause have debilitating symptoms? The answer is surprisingly better than 75%. It's up to 80%. And women are told, well, deal with it, man up or woman up or whatever, buck up and deal with it. And by the way, it lasts only a year or two. No, it lasts a median of 7.4 years. 7.4 years. Women of color, it lasts a median of 10 years.
Unbelievable.
Unbelievable. It affects women in the workplace. Approximately 40% of female women in healthcare delivery in England, 40% are retiring early because of these symptoms, which are incapacitating and holding women back in many, many areas. And these symptoms can be eliminated in better than 70% of affected women and dramatically eliminated. And if you have a buzzword like breast cancer and you wave it, it forces people to back away from this as if it's radioactive. When the Women's Health Initiative was first published, the result in July of 2002, the headline in the New York Times said it increases the risk of heart disease, it increases the risk of cognitive decline, it increases the risk of breast cancer, and it shortens life. Every one of those statements has been walked back, and all but one have been disproved, although we can disprove that last one as well.
So I just want to ask, because this initiative was founded with the right intentions, right? Like, we are going to study about women's health using women. We want to do this right. We want to do the research properly, like, great intentions. And yet something went wrong, something went awry at some point in the process. And I want to make sure we get to the information part of it, not the kind of what went wrong, because people can read the book and get all of that. Cara, yeah.
Yeah, I just want to chime in that Estrogen Matters is about 330 some odd pages. And just so our listeners are clear, there are more than 50 pages of citations, of studies backing every single statement you are making. And on each of these 50 pages, there are probably anywhere from 7 to 10 different studies cited. So the volume of data that you went through in order to document the statements that you are making, it has to be said really clearly for people. This is not like, oh, I read this study, the Women's Health Initiative, and I didn't love it, and here are my issues with it. We have hundreds and hundreds of citations combing through the data, point by point by point, to argue why the Women's Health Initiative data that essentially turned off the prescribing of HRT, hormone replacement therapy for women. And just to be clear, that's estrogen plus progesterone, generally speaking. Right? Is that a fair definition?
Fair enough.
It's very, very important. This one study stopped the prescribing of these medicines, of these hormones, and these hundreds of others have lots of other information to provide.
This is the first book I've written, and my writing up until this point has always been for medical publications. So it was written as if it's a medical publication. It was written with Carol Tavris, who is a brilliant data obsessive, but who has a way of smilingly, sometimes with a little, yes, that's exactly right. Thank you, Vanessa. saying something. So it's a very readable book. It was written for people, lay people, but it was written so that doctors could read it too. And so we wrote it with all these references. I'm I'm actually from New York, but I've been in Los Angeles for many, many years. And it's very easy to say, are you really going to believe a Los Angeles doctor?
Oh, people say that all the time.
Only if
All
he's
the
from New
time.
York originally will I believe a Los Angeles doctor.
Hey,
There you go. So it was very important that we establish credibility. And like you've done in your book, we are data meticulous. And
Right.
that's
So
why-
when you fly in the face of, and I use those words very purposely, of a sort of globally accepted proclamation from the Women's Health Initiative that says, using hormone replacement therapy puts women at risk for these many, many things. And you are here shouting from the rooftops, Avrum. No, it doesn't. It actually helps them. And here are the ways it helps them. That is a very brave thing to do. What you are doing, what you have done is very brave. And there are lots of people walking, in the footprints that you have laid out since taking that very brave step. And we've had some of them on the podcast. But what did it feel like to really get up there and actually be in conversation with some of the people whose very research, you disagreed with and were saying, no, this is wrong? What was that like for you?
It didn't require bravery because there was no alternative.
Mm-hmm.
This is something that was clearly necessary. The disagreements are almost gone.
Mm-hmm.
I have been in touch with major people from the Women's Health Initiative and thought leaders and respected investigators around the world on this subject. And it's important that people realize that there isn't much of a disagreement. Just for example, when the Women's Health Initiative came out in 2002 and hormones dropped precipitously, that wasn't the end of the story. They've continued to publish up until and through this year. And in 2003, they published a paper that reported that hormone replacement therapy had no effect on quality of life. And the first question is, what planet was this study run on? And when you read the article actually is clear, but the headlines don't pick it up. The article says this was a prospective double-blind randomized study, which means neither the physician nor the patient knew whether they were getting a placebo pill or the medication. And it says we knew that symptomatic women would know within a week whether they were getting the sugar pill or the hormones. And so we intentionally omitted symptomatic women from the study. And of the 16,000 women we treated and randomized, about 13% had symptoms. But the overwhelming majority didn't have symptoms. And perhaps not surprisingly, giving hormones to the asymptomatic women had no effect on the symptoms they didn't have. But the result in the headline in the New York Times was hormones have no effect on quality of life. Parenthetically, on the 13% who was symptomatic, yes, they did have improvement, but they were swallowed up by the other 87%.
And I think it's a really important 2-point conclusion to come to for a second, which is number one, over the past 20 years, there has been increasing consensus here. And number two, as someone who was so symptomatic, I don't think it took a week. I mean, within 48 hours, my life had changed. And every single symptom that you and so many others talk about, that I'm educated. I read everything. I had no idea half of them were related to shifting levels of estrogen and progesterone in my body. And I started these hormones, and everything got better within 48 hours. It was unbelievable.
So let's just go over the other things that we've already touched on. Heart disease is the leading killer of women in this country and in the Western world, responsible for 7 times as many deaths each year in this country among women as breast cancer. And what people say to me when I say that is, sure, but old women die of heart disease and young women die of breast cancer, and I'd rather die when I'm old than die when I'm young. But that's not correct. In every decade of a woman's life from 40 on, her risk of dying of heart disease is greater than her risk of dying of breast cancer, and the difference increases in favor of heart disease with each decade.
That's right.
Estrogen reduces the risk of significant cardiovascular heart disease by 50%. And we've known that for 40 years, longer than 40 years. And the Women's Health Initiative that reported an increased risk of heart disease reported it because, in spite of their saying, we were looking at typical healthy women in the study, 50% of the women were smokers, more than 50% were overweight, with a significant proportion being obese, and the median age was 63.
Right.
Estrogen decreases the shrinking, the narrowing and calcification of vital arteries to the heart, to the brain, to other parts of the body, as long as it's given to women with healthy arteries. Once those arteries start shrinking, estrogen has the ability to cause clumping of platelets, which are small corks that circulate in the blood that help prevent bleeding. A platelet clump can obstruct an already narrowed artery. And so if you're going to give estrogen to women with already narrowed coronary arteries, you will increase the risk of a possible heart attack. By the way, that increased risk seems to be prominent only for the first year after estrogen is given, but nonetheless, that could be very serious. And so estrogen and estrogen progesterone for women with a uterus should be started when a woman still has healthy arteries, when she's in early perimenopause, somewhere between 45 and 55, and not 10 years after her last menstrual period. And when it's done that way, and the Women's Health Initiative data support this, it does decrease the risk of significant heart disease, as do all other studies. Osteoporotic hip fracture, if you listen to television, you're advised to take calcium and vitamin D, and I have no problem with calcium and vitamin D, but for a postmenopausal woman, it does nothing to prevent the hip fracture. Calcium and vitamin D may increase bone density, but the problem with aging bones is not that they're not dense enough, although that can be a contributor. It's that they lose their elasticity. A bone should be able to stretch to some degree without fracturing. If it becomes more fragile, it breaks more easily. Estrogen maintains the bone's ability to stretch. And once that's lost, giving calcium and vitamin D does nothing. Osteoporosis is not reversed by estrogen, but it's 50% reduced by giving estrogen to women who are still healthy. And there's never been disagreement about that. And the other things that are recommended, like bisphosphonates, which are medicines that can also improve bone density, are nowhere near as effective as estrogen in preventing hip fracture. And we go into that in detail in the book.
So, Avrum, let's pick it up with the demonization of estrogen. And I'm going to paint a picture for you. In the world of pediatrics, one of the most common visits in a pediatrician's office is, I've just discovered a lump in my breast. And you might think that this is a worry for an older teen who has been evolving through the stages of breast development, but nope. It's a breast bud. It's a tween, usually someone who's 8, 9, 10. And at the very, very onset of breast development, what happens? They have a little bit of swelling and a little bit of firming underneath their nipple. It almost always happens on one side instead of the other. And either the child or the parent or both come running to the pediatrician to say, I think it's breast cancer. This is so common, in fact, that we have started doing education in schools, telling kids, hey, don't worry, it's a lump. It's going to show up on one side before it shows up on the other in most people, and it's not cancer. So the culture has created this story that breast cancer is everywhere because it's a common cancer. And estrogen is like the Maleficent of the tale, right? That's the bad actor, and we should all be afraid of it. And as I was reading Estrogen Matters, I couldn't help be struck by the fact that I was actually texting so many of my friends who are mid-treatment for breast cancer or who are breast cancer survivors saying, have you read this? Have you read this? Have you read this? Because so much of this idea of the badness of estrogen comes from the therapeutic approach to their mother or grandmother or aunt or uncle or father or grandfather's breast cancer. So can you talk a little bit with that whole long tee up? Can you talk a little bit about what is the biggest myth about estrogen and how can we reframe our thinking so that tweens are not terrified of a hormone that their body produces as part of their sexual development and part of the rest of their life, their health?
Our politicians know that one of the most motivating emotions that you can generate is fear. If you want people to move in a certain direction, use fear to motivate them. Breast cancer is just what you described. It is that kind of fear, which is why I started by talking about the current cure rate for breast cancer. Jacques Rousseau is the cardiologist who was the initial principal investigator on the Women's Health Initiative. And the Women's Health Initiative stated that we know that there are many papers supporting the benefits of estrogen, specifically for the heart, which is what it was set up to study. And we thought that the Women's Health Initiative would confirm the results of those papers. Except if you look at Jacques Rousseau's published papers, 6 years before that first Women's Health Initiative result was published, he published a study saying the estrogen bandwagon is out of control. It's time we put brakes on the estrogen bandwagon. That doesn't sound like an impartial investigator who's given $1 billion to show that estrogen is of benefit. And he succeeded in putting brakes on it. That first paper that said that hormones increase the risk of breast cancer. Well, first, estrogen was never shown to increase the risk of breast cancer in that very large study, ever. And the current Women's Health Initiative reports that continuously reevaluate the data now say that women who were randomized to estrogen alone had a 23% decreased risk of breast cancer development, and even more importantly, a 40% decreased risk of death due to breast cancer, estrogen alone. The women in the Women's Health Initiative who were randomized to take estrogen never had breast cancer.
Okay.
But estrogen reduced the risk of developing breast cancer and reduced the risk of dying of breast cancer among that population of women randomized to estrogen who never had breast cancer.
Okay.
Now, in fact, estrogen was used, and you're correct, Vanessa, but it wasn't the point I was making. Estrogen was used to treat breast cancer before we had better treatments. And in 1944, estrogen was shown to decrease measurable breast cancer in close to half the patients who received it, but we have better treatments now.
Okay.
So we don't use, and it was high dose estrogen, we don't use that anymore.
Got it. Okay.
Okay.
Can you clarify one thing? Because we've referred to it a few times, which is for people with uteruses, it's a
Yes.
combination of estrogen and progesterone. Can you
Yes.
explain why that is important as people are considering their own, decision making and choices?
Sure. Estrogen stimulates the lining of the uterus, called the endometrium, to proliferate. And if it's given alone, there is an 8-fold increased risk of some of those cells becoming malignant. Now, uterine cancer is largely curable, but who wants to induce cancer in a
Right.
woman who doesn't have it? And there was a drop in the use of estrogen in the late 80s when that was identified. And that drop continued until it was found that progesterone causes the uterus to either slough off those extra cells that are produced, or if given together with estrogen, prevents those extra cells from being produced, so that the increased risk of uterine cancer is eliminated in women who have a uterus if they're given estrogen and progesterone together.
But progesterone's kind of a drag, right? Like it's not as magical a hormone
I wouldn't
as
call it a
estrogen.
drug.
There are some side effects from progesterone that don't have the shimmering unicorn glow that, the wonderful aspects of estrogen. Do you want to reframe that statement,
Yes.
Avrum?
Well, it's okay. If I'm opening a corner candy store and I'm marketing something that sparkles, I would rather market estrogen than progesterone.
Yes, correct.
But progesterone is getting a bad rap here.
Okay.
Mhm.
And the reason they're getting the bad rap is I mentioned that the Women's Health Initiative showed that estrogen not only does all the wonderful things we spoke about, it decreases the risk of breast cancer among women who never had it and decreases the risk of death from breast cancer among women who never had it compared to women who never got estrogen. The Women's Health Initiative in 2002 said, although estrogen didn't increase the risk of breast cancer, the combination of estrogen and progesterone did increase the risk of breast cancer. And that is a lie. Ooh, what a strong statement from a Los Angeles doctor. What do you mean a lie? Well, what they said is there is a 26% increased risk of breast cancer. This is true in the Women's Health Initiative when you compare women who got the combination with women who got the placebo. But they said that increased risk, and this is a direct quote, almost approached nominal statistical significance. I mean, we play basketball. I don't, but I know many people do. And there are rules in basketball. In order to get 2 points, the ball has to go through the basket. A rim shot where the ball bounces off the basket doesn't give you any points. Almost approached nominal statistical significance means, well, the ball didn't go through the basket, but we're going to claim it's significant anyway. Cara, I have never seen that in any medical peer-reviewed publication.
Well, I mean,
ever read.
it speaks to your fear comment, right? I mean, it's,
Yes.
that is what that is.
Yes, there are many different ways that hormones can be administered. They should be divided into local, which really means vaginal or even on the face in low dose, or systemic, which means by pill. There are other ways of doing it by injection, although those are not recommended. The Women's Health Initiative that showed the 23% decreased risk of breast cancer, 40% decreased risk of death from breast cancer was the pill. Fine. But when the Women's Health Initiative came out, seeing a commercial opportunity, people said, oh, wait a minute. That was a pill. It was a particular pill. It was Premarin, which is an acronym for pregnant mare urine, which sounds terrible, but it's a pill and it did these good things. And so there were other preparations marketed. The word bioidentical came into the literature because it's estrogen, but marketers were able to say, well, the pill, that's bad. But that wasn't bioidentical. And bioidentical, which is a marketing term here, is
brilliant marketing term.
Yeah, without other data, I have no objection to bioidentical or the Premarin pill. The fight we are having is for legitimacy for estrogen, but it's important to mention that the word compounding means that whatever you are taking isn't FDA approved, which bioidentical can be FDA approved, the pill can be approved, so can the patch, so can cream. Compounding means it's done by a local pharmacy. Many local pharmacies are very, very good, but without FDA approval, there is no uniform guarantee that what you're getting from your compounding pharmacist is good enough, meaning it's dose regulated, it's free from other contaminants. So that's one issue. Compounding, except for rare cases where people may have allergies to the FDA approved form, should not be approved now.
And in terms of absorption of these products,
I'm going to get to that now.
Go for it.
Then the next question is, people say, well, don't worry, this dose of vaginal estrogen or this coil that you're putting into your vagina isn't really absorbing estrogen. Well, the first question is, if you've been listening to what we've been saying up to this point, what's the big deal about absorption? I mean, if estrogen is a good thing, although taking it locally does not give you the doses that cause the benefits that we're talking about, locally meaning intravaginally primarily, but if it's absorbed, if it's not absorbed, frankly, Scarlett, I don't care.
Wait, so Avrum, I want you to expound on that point a little bit.
Yes.
The health benefits, the reduced risk of breast cancer, the cardiac benefits, the cognitive benefits of estrogen, you don't see those benefits based on the research if it's used locally, only if it's used systemically. Is that correct?
That is correct, but it's important to amplify that and say that by locally, we specifically mean intravaginally. And it is very good for the genitourinary symptoms that we spoke about. I'm not so sure about libido, but certainly about frequent urinary tract infections and painful sexual intercourse. It's very good for that. Systemically can be the pill or can be the patch or can be localized cream. And then the question is, well, which is better, the pill or one of the forms? And there are lots of claims, and we could spend the next 2 sessions talking about that right now, because I want to make sure we make the key points. Again, it doesn't matter much. There may be some studies quoting that one may be a little better than the other in terms of heart or brain effects. If it is, those differences are minimal. The patch and the skin application are quoted as being much safer because they don't increase the risk of venous clots, thrombophlebitis, clots in the veins. Well, that's true. They don't increase the risk of clots in the veins, but the increased risk from the pill is very, very, very small.
So, Avrum, if you could write your own headline, if you could take back all of the headlines of the last 20 years that were caused people to be afraid, who caused people to make healthcare choices that were based on inaccurate conclusions, or misread data or whatever. And you could be the headline writer of the New York Times. What would those headlines, how would those headlines read?
Well, first, if I'm given that opportunity because somebody at the New York Times is listening to this podcast, which is very possible, I'm going to think long and hard about it, not do it off the top of my head. But having said that, what I'd like to write is these points are points of agreement. Get rid of the confusion. It is so easy to take advantage of the confusion. And if we could say, look, we agree about symptoms, about quality of life, about heart disease, about osteoporosis. We didn't even get into cognitive decline, but we agree about that also. We agree about estrogen, and the combination doesn't increase the risk of breast cancer based on the largest study that we know of. So talk with your doctor and get that brush fire out of the conversation. That's what I'd want people to do.
And if they, because what I admire about you is you will not give blanket advice, just like we will not give blanket advice. We will give people points of data and some guideposts, and then they have to go speak to their own healthcare providers. As women approach their healthcare providers and think about how to care for themselves and also teaching the kids in their lives, who do you trust? How do you make decisions? What are your guides? What advice do you have, Avrum, for people trying to weigh the information, the impact on their lives, all of those things? What is your overarching guidance to them?
Richard Feynman is one of my heroes. Richard Feynman is a Nobel laureate physicist who played the bongo drums and was working on the Manhattan Project. And there were many books written about this eccentric man. And Richard Feynman said, observation is the judge for what is scientifically accurate. Something, if you do something, see if it works. If it works, then at least at that point in time, it is scientifically valid. If it doesn't work, I don't care how beautiful your theory is, it is not scientifically valid. So the questions that we can answer as physicians or as guidance counselors is what works. We can't answer questions scientifically like, should I do this? It's not a question that can be answered scientifically. And a lot of people confuse that. And I know that you and I get those kinds of questions. And it's important that we don't get so full of ourselves that we think we can answer those questions authoritatively.
And for those of you who read the book, Avrum, you wouldn't even tell your daughter what choice to make. You told your own daughter, here's the universe of information. Here's what I know. You have to make the decision. So I want people to be super, super clear. It's not just you on a podcast. It is your life philosophy to follow the data and empower other people to make decisions about their own lives based on the guidance and advice they get from their healthcare providers. This is not you just doing lip service. This is how you have lived your life.
I agree with that, Vanessa, completely.
I know people have so many more questions, and many, many, many of those questions will be answered if you read Estrogen Matters. It is fascinating. It is absolutely fascinating. And it's a real emotional roller coaster. I mean, it is a melodrama. It is a telenovela of scientific communities coming together and in some ways coming apart. So I encourage people to read it. Avrum, this was totally fascinating. We are so grateful to have you on, to have your knowledge and expertise. And I didn't even know you when I was in high school, and I still enjoyed it.
If I knew you were this cool, I totally would have hung out with you at high school graduation.
I
That's
wasn't
the
this
truth.
cool before.
Well, yeah, I think you might have been. I think you're bearing the lead there.
Thank you.
I hope you will come back and visit us again, and maybe the world will have shifted even more from your advice and you don't call it bravery, but I think it's very ballsy what you have done and how you've taken a stand on this.
One of the things that we're doing now is I mentioned that there is still a black box warning on estrogen products from the FDA that came out within a year of the first paper in 2002. We are trying to get that black box warning lifted, and I'm working with physicians and academicians around the world, many of whom depend upon the FDA for guidance. And we're trying to make a difference.
There's a lot about that on social media, and it's a really interesting mission. I think talk about rebranding. That's a must do if estrogen is going to be rebranded.
Exactly right. Instead of standing in place and either yelling at the moon or crying, we want to make a difference.
Yeah.
Yeah.
What a
This has been
pleasure.
a joy, ladies. Thank you.
Thank you. Thank you for coming on.
Thank you.
Okay.
Thank you so much for listening. You can email us with questions, feedback, or episode requests at podcast@lessawkward.com.
If you want to learn more about what we do to make this whole stage of life less awkward for everyone involved, our parent membership, our school health ed curriculum, our keynote talks, and more are all at lessawkward.com.
And if you want products that make puberty so much more comfortable, visit myumla.com.